Treatment will come at lunch.
I was just wondering whether the 7-minute MRI that shows the grey matter, whether there's anywhere in New Zealand that can do that?
No, there's something that we can do, which the University of Auckland scanner does, which is called double inversion recovery, which picks up about 1/3 of the lesions that this new one does. It's not as good. One of the difficulties is that although we could do that form, you know, the less good sequence, people aren't necessarily experienced at reporting that. So this is something for the future, rather than something that we've got right now.
Question here.
Can you comment about whether there's any relationship between fatigue and whether it occurs in the brain or in the spinal cord?
Yeah, look, that's really interesting. Overall, like disability, there's quite a poor correlation between brain lesions and fatigue. People have looked at this. And fatigue, in my mind, is more of a manifestation of MS globally affecting the brain rather than, oh, you've got...
That are being trailed.
Yes.
Is there a common ingredient? For instance, you had fluoxetine, you had something being used by motor neurone.
Yep.
I think somebody talked about lamotrigine this morning.
Yeah. So a number of the treatments, the one that the medicine for blood pressure and phenytoin and that Dr. Brownlee mentioned, are treatments that target sodium channels. So the way that nerve cells speak to one another is through electricity, and the electricity gets generated by changes in the levels of sodium and potassium within the nerve cells. And when demyelination occurs, which is one of the basic problems in MS, the sodium and the potassium channels change. And there's evidence from, if you give a rat MS, which you can do in a laboratory, that treatment with these sodium channel blockers can not improve their disability, but make the course of their MS less severe. And so sodium channel blockade is a major interest. The treatment for motor neuron disease, riluzole, targets a system in the brain of neurotransmitters called glutamate. And we know that high levels of that substance are toxic to brain cells. And reducing it with the riluzole treatment might be a way of protecting them. So in short, there's multiple different avenues that people are doing. And the MS SMART study that I mentioned, where they're testing 3 agents versus placebo, they're trying to make it more streamlined. So instead of doing 4 separate trials, they're trying to do one big trial all at once, which I think is really exciting, because clinical trials take a long time, and instead of having to wait for 4 trials to be done, we're going to get an answer on all those 3 substances all at once.
Question here. Did you have a question?
I was actually just wondering, has there been any trials or anything why it always starts with optic neuritis?
Yeah, it's really interesting, isn't it? Yeah, that's a really good question. It's such a common way for MS to present. The way I think about it is, you're right, it's often optic neuritis, it's often numbness and tingling as well. That's also a very common first symptom. And the way I think about it is that if you've got a bit of inflammation in your optic nerve, okay, which is the size, smaller than the old 1-cent coin, very, very small structure, or the spinal cord, which again is small, about the size of a 50-cent coin, you're going to know about it usually. You know, it's going to be affecting something, as opposed to in the brain, where lesions can form and people, you know, have no symptoms at all. It goes back to that old adage of you only use 10% of your brain. Has anyone ever heard of that? Yeah. It's not quite true, but it sort of works quite well for in MS. So I think that optic neuritis is a common first symptom because it's an area that if you get inflammation there, you've got to know about it.
Question over here.
Hi. Earlier in your talk, you mentioned about lesions on the spine and the correlation between that and disability.
Yes, yep.
Now, whilst that might not be your focus, the conclusions you wish to draw from your research, would you be able to perhaps hand that on to someone who could follow up and therefore not waste more time by having to do their own research? You know what I mean?
Well, I'm really interested actually. I'm going to take it forward, this cord lesions thing. So what we found is that at 5 years, the cord lesions are really, really important. And it's interesting because a lot of those people didn't have spinal cord problems. They were coming mainly with visual problems, but they had lesions on the cord. And we're going to be looking at them after 15 years to know, is it still important after 15 years? Because if it only matters in the first few years, that's less important. People are more worried about how they are in the much longer term rather than the first few years. But certainly when I see people in the clinic who have had a first attack and they've got several lesions on the spinal cord, I feel quite worried about that person.
Maybe if they focus on the lesions on the spinal cord and they find something that they can inject or use for to focus on those rather than a tablet for your lesions on your brain.
On the brain, yeah. Yep, definitely. I think that MRI scans are getting better and our ability to get good pictures of the spinal cord is improving, and going forward we've got to make sure we don't ignore the spinal cord, because so many of the most important symptoms of MS are related to the spinal cord.
Could you comment on that HIV virus treatment MS correlation for us?
Sure. So Mr. Matthews asked me in the break about HIV and MS. So not as many people with HIV have MS as they should. And we don't know for sure why that is. But we think that the drugs used to treat HIV infection may suppress other viruses that may be relevant to the development of MS. And a trial that I didn't mention, but another trial that is going on in London is we're treating people with early relapsing remitting MS for a year with an HIV medicine. And they're coming for a scan every month to see if the HIV medicine has any effect either on lesions forming, areas of inflammation, or on brain atrophy. I think that things aren't, it's an interesting area, but I don't think well worked out at this stage exactly what's going on.
Sorry, can we take the question over here, please?
Hi.
Hi, I was diagnosed in 2000 with MS. My first symptoms were in '89.
Right.
I had an MRI scan in Sydney, which was inconclusive, and it took them 10 years to diagnose it.
Yeah.
I'm now in a secondary progressive stage, but it's only been in the last 4 years I need assistance walking.
Yep.
And very limited in how far I can go. Does that mean then that things have moved into my nervous system and the brain, or is it just the way the progressive will go? Because the MRI only put the lesions on my spine.
There were no lesions on the brain when you had your MRI scan? And that was back in '89, or that was in 2000?
2000 when it was diagnosed.
Yeah. Well, it's difficult to say without doing another MRI scan, of course, to find out what's happening in the brain. I would have thought it would be likely there would be brain lesions now, 15 years later, but I can't say for sure. So some people do just have changes on the spinal cord, but no lesions in the brain. That's uncommon. In those 178 people in this study, there's one person that doesn't have brain lesions, but does have multiple lesions in the spinal cord. I think that's an unusual form of MS, but part of what we see.